So just to continue, there are a couple more differences between 2012 and 2017. In 2017, we have new guidelines which were not present before. One of them is that if your lipid level is still above 70 milligram percent per deciliter, despite maximally tolerated statins, we have now large trials like the Improve It, which show that you can add ezetimibe, and this is now recommended in a color yellow, meaning you should probably do it, or you can do it. And the Fourier, using PCSK9, using evolocumab, which again showed a reduction in events and shows that if those patients the patients at high risk still have high cholesterol, not reaching the target, they're still above 70 after maximum dose of statins, you can definitely give a PCSK9 in indicated patients. Finally, the complete revascularization during the index primary PCI in STEMI patients who are in cardiogenic shock is now accepted. This might change because there is a new trial showing that this is not such a great thing. So it's yellow. I would say in the next guidelines it's probably going to be orange again. Finally, what if the patients have not received any dual antiplatelet and they have to go in very quickly? We have one trial, which is the Champion trial, showing that you can use the ultra short acting parenteral cangrelor. You don't have to, so it's orange, but you can. It's recommended after fibrinolysis as an expert opinion, level of evidence C, to switch, if your patients had been on clopidogrel, for instance, to switch to ticagrelor after 48 hours. This is an expert opinion, and after the TREAT study is probably going to get a higher level of evidence in the next guidelines. Extending ticagrelor up to 36 months in high-risk patients based on the Pegasus STEMI 54 is something that you can do on a smaller dose of 60 milligrams, and using polypill to increase adherence has been trialed. Finally, the last thing is that the routine use of deferred stenting has become red. Do not defer the cases. It does not work very well, and we know that from the Dynamic 3 deferred trial. The last lower right portion of the slides, class 1 is green, 2A, meaning you can and it's better to do it, is yellow. 2B, meaning you can, but it's better not to do it, is orange. Class 3, meaning you shouldn't do it, is red. What is also new in the 2017 guidelines on AMI, acute myocardial infarction, and STEMI? We have some revised concepts. One of them is the MINOCA concept, the myocardial infarction in normal and what looks like normal coronary arteries, and quality indicators. And this, the quality indicators of work in hospital. This has been discussed in fully dedicated chapters, which I'm not going to go through now, but I would strongly recommend that you look at MINOCA and at the quality indicators, which show how well your hospital is doing compared to other hospitals. You should also realize that there are some new definitions in strategy selection and in time delays. For instance, the definition of first medical contact. It was not very clear. What does first medical contact mean? Does it mean when the person receives the ambulance, or when they reach the hospital, or when they get diagnosed? The definition of time zero to choose reperfusion, that's when the strategy clock starts ticking, is now the definition of STEMI diagnosis. Selection of primary PCI over fibrinolysis is now when anticipated delay from STEMI diagnosis to wire crossing is less than 120 minutes or equal. So look at those. STEMI diagnosis is a much better definition than first medical contact. Wire crossing in the infarct-related artery is a much better, clearer term than door to balloon. Door to balloon was not very clear. So STEMI diagnosis to wire crossing. The maximum delay time from STEMI diagnosis to fibrinolysis, if you decide that you're not going to do primary PCI, is now 10 minutes. 10 دقايق. If you decide that you're going to give your patient a blood thinner TPA or streptokinase, and you're not going to take them to primary PCI for a variety of reasons, you should start your drip in 10 minutes from STEMI diagnosis. The door to balloon term is gone. We don't use it anymore. Please don't use it anymore. So what about the time limits for routine opening of an infarct-related artery, the IRA? 0 to 12 hours is class 1. If the patient is coming to you in less than 12 hours, you have to open that artery. 12 to 48 hours is class 2A. It's yellow. The first one is green. More than 48 hours is red, is class 3. The ECG at presentation. If you get a patient who looks like a STEMI and who has a left or a right bundle branch block, they're considered equal now, not the left bundle alone like the older guidelines, for recommending urgent angiography if you have ischemic symptoms. What about the patient who gets successful thrombolysis and is doing really well? What do? You should take them to angiography in between 2 hours after thrombolysis up to 24 hours, not earlier or not later after successful thrombolysis. The patient should be in a cath lab. Finally, what about the patients who are taking anticoagulants? You have whole chapters in the guidelines for acute and chronic management presented, which in the next presentation, which is upcoming now, I'm going to discuss those DAPT guidelines. Thank you very much, and I'll see you in the DAPT guidelines.